right. So we are live on Facebook. Welcome, everyone. This is our educational webinar series with the Autism Society of Texas. This is our Autonomy series, which is geared towards autistic adults as the audience. And this month, we are excited to have the topic of autism and aging. Which is an important discussion for our community. So we're very excited to have two wonderful presenters here to talk about how autism can impact older adults in the aging process. So I will go ahead and hand it over to our first presenter, Jeff.
Thank you, Dana. My name is Jeff Owens, and I'm an autistic advocate, and I run two websites. The first is autism-101.com, which is mainly focused for late diagnosed autistics or people that think they may be autistic, to find some more information, resources, and get engaged with the autistic community. The other one is autisminthemedia.com, which lists all the TV shows and films where autistic or autistic coded characters are in. So for today's topic of autism and aging, I thought I would start by just giving a brief definition of what autism is. It's a neurological and developmental difference that is naturally occurring. It's not a disease, and it can't be cured, and it's always existed. There's been recent commentary that there's quite a bit of autism diagnosis being noted by people. They're seeing that on social media. But a lot of that has to do with better diagnostic tools and training and the broadening of what autism is as a definition. And we'll get into that in a little bit. So each person, autistic person, presents their autism differently. Many of us have different co-occurring conditions. So we have a saying in our community: if you've met one autistic person, you have met one autistic person. And that's very true. Many autistic people have high support needs. Some have low support needs, and all over. And then we each have individual, often co-occurring conditions. Some may have learning differences, intellectual disability, speech issues, and so forth. And autistic people look like everyone else. You can't tell someone's autistic by just looking at a picture of a person. And autistic kids grow up to be autistic adults. So what's important as far as the topic today is what I'm consider the graying of the population globally and how autistic people fit within that. And what I mean by the graying of the population is that the World Health Organization has indicated that between 2015 and 2050, the world's population over 60 is going to nearly double to 22%. And that means there's going to be a lot more autistic people, obviously, in this group. And the first generation that was diagnosed autistic are now entering middle age. And there's a big unidentified group of people age 50 plus. And there's a lack of research and services for autistic seniors. There's generally been a gerontology and autistic research have historically been kind of siloed, and they're just now building the bridge between the two of those. So then we can ask, well, why did a lot of these people not get diagnosed, many years ago? And that really has to do with the evolution of autism, the term autism, and how it finally got into the DSM, um, it was really just in 1943 and 44 where it became the condition autism became um, sort of standardized with Kanner and Asperger. And it wasn't until 1980 that it actually became part of the DSM-3 list as infantile autism. And it's worthy of note that um, most of those that were diagnosed were white male children, and many of them had a co-occurring intellectual disability of some kind. And it wasn't until 1994 that the definition of autism broadened and they introduced Asperger's, which were autistic people that didn't have an intellectual disability. And of course, that included a wider group. And now in 2013, we have the latest definition as they've learned more about how autism um, works and how it's presented in different people. Now it's considered autism spectrum disorder. And so, as you can see, it started from a very smaller group that were being diagnosed, white male boys mainly, that had usually some sort of intellectual disability or learning differences, all the way until now it's a spectrum. And there are people that have low support needs, all the way that to autistic people that need full-time care. So it's not really an epidemic. It's just really, I would call it an awakening now that the definition is broadened. So today we're really going to be focused on those that are 50 plus, and specifically two groups: those that were diagnosed early that are now aging, and those that are termed the lost generation, those that got diagnosed really late in life or are still walking around undiagnosed and struggling. So the natural question is, well, why were these people missed? Well, as we just looked at, the historically, the definition, there were very few females that were diagnosed, and many people learned to mask or camouflage their differences to survive, especially those with lower support needs that were able to go to school and some even to have employment. So their traits were often attributed to other things like, oh, this person's quirky, they're shy, or they're difficult. And these people often got misdiagnosed with other conditions. So oftentimes with this type of group, there can be a specific trigger that happens for the person to get this late diagnosis. Um, Burnout is a common one that we hear, where people have been masking for decades and they finally just can't do it anymore. And so um, a lot of times depression happens with that, and they end up getting an autism diagnosis. Um, there's perimenopause and menopause for women that can intensify the sensory and executive function struggles that many of us have. There can be major life transitions, such as retirement for those that can work, or becoming an empty nester, or loss of a spouse that removes stabilizing routines for the autistic person. And often we hear of parents or grandparents that see their own traits in their child that's or grandchild that's being assessed, and say, well, I do all those things too. And sure enough, because there's a big genetic component to autism, often that leads to a diagnosis for the older person. So this discovery, and there's a good book called Lost and Now Found, that lists a lot of people's experiences being uh, diagnosed very late in life. There's many different sort of stages of feelings that an autistic person might go through, and many do. Some have a profound relief and validation that they're not a broken person, that they're just autistic, and that there's a name for what's going on in their life and their struggles. Others have a profound grief and anger over lost opportunities and decades of struggle without any support. And there's sort of a reevaluation that happens where you look at your life through this new autistic lens and things start to finally make sense. And sort of as an example, I thought I would use a case study that's just kind of a compilation of different things from that book I mentioned, of this fictitious person named Susan, who was a retired librarian. And she was always called shy and rigid by others. And the trigger for her late diagnosed autism was that her husband passed away just 2 years ago. And the loss of his support, for handling, bills, driving, social buffer, caused her just to collapse. And so she was diagnosed with treatment-resistant depression and early onset dementia due to confusion, when in actuality it was just brain fog and burnout from having to suddenly deal with all of these things that she just can't do very well. And the realization for her was just reading a memoir by an autistic woman. And as she was reading all of the traits of this autistic woman, she recognized herself. So each autistic person has oftentimes these sensory differences. So processing everyday sensory information can be really difficult for autistic people. That's why you see many of us with headphones and sunglasses. But some of us are all actually look for are sensory seeking. So it's a range of autistic people with a combination, and some can change day to day, but it's well outside the normal range of most people. Um, and when we're thinking about how sensory issues work with autistic people that are aging, it doesn't mellow. The sensory issues don't go away with age. They don't mellow. It actually becomes harder to manage, according to a lot of autistic people who have been asked that question. And there's logical reasons for this. So older autistic adults report lower ability to cope because they've used so much energy to mask or push through in their 30s that they just don't, they have nothing left. And because naturally, as you age, your hearing and vision, uh, you have some loss there, that increases your brain's cognitive load on processing those things. It's harder to interpret the data, and it leads to overload quicker. And after 40, our nervous systems just handle stress less efficiently, and that can lead to more painful physical issues. And that kind of leads to what I call the double whammy of aging and autism, how they interact bidirectionally. You've got the aging processes, which we just talked about: cognitive slowing, physical decline, that can exacerbate our autistic traits, such as our sensory sensitivity and executive dysfunction. And you have a lifetime of stress and sensory overload and masking. And so that's kind of the key concept that I'd like for everyone just to think about, is that these stressors become often worse as we get older and require more support. And there's healthcare barriers that often happen with autistic people. There's often times difficulty with us describing our pain and in a way that can be communicated clearly to a doctor. Doctors can often misinterpret our flat effect on our expression or our direct, blunt communication as being non-compliant. And then autistic people have to deal with the bright lights in the waiting rooms and the and physical exams, and a lot of us don't like that, and so we'll avoid getting the care that we need. And of course, there's co-occurring conditions. There's much higher rates of anxiety and depression and GI issues and sleep disorders that complicate things. So those three things, the sort of the sensory age-related vision loss and the autistic sensory processing, the executive functioning as you're aging. Your working memory gets worse. Your autistic's brain, already working hard to organize things, can begin to decline. And then you don't recover as quickly from burnout. It takes you much longer at 60 than it does at 30. And our network of support begins to shrink for some of us. Those that we relied on in our youth may have passed away, like our parents, or a spouse, and losing them can be catastrophic, because we just um, need that extra support. And for some, there's a fear of the group home, losing independence if we've had independence, um, and ending up in a communal senior living situation, which is very rarely centuries friendly. And then, of course, uh, many of us are underemployed. And so the financial resources as we get older may be very scarce. And as I mentioned at the very beginning, we all have I don't think I've met an autistic person that doesn't have a co-occurring condition, and usually many. Here's just some of the more common ones. For instance, like in 40 to 70% of autistic people, studies have shown, may have ADHD in combination with autism. Now, there are some autistic advantages, having a different, uh, we're better equipped to handle things like solitude, for example, than our neurotypical peers. And of course, our special interest, our passionate interests, provide us deep engagement, and joy, and can provide some cognitive protection. Um, and because we don't necessarily care about societal expectations of how to act, there's sort of less pressure to conform to those because most of us don't care. Um, and so that leads to, supporting older autistic adults. Um, believe them. If they say they are autistic late in life, validate it. Don't demand for those that can't afford it, or don't have the means to get a formal diagnosis. Don't demand that from them. Just believe them and support them. Um, for living spaces, looking for sensory triggers is very helpful. For lighting, humming noises and textures and smells and all of those things that can affect a living space for an autistic person. And in healthcare setting, just clear communication, and planning and using literal, clear language are very helpful, um, to allow us processing time. And for social aspects, connection doesn't have to mean group activities in this noisy senior center. Um, so moving forward, unmasking is really crucial for us as we age, because we just can't mask very well as we age anyway. So we need to preserve our energy by stopping the performance of what I call neurotypicality, and allow things like stimming and sensory aids in public without shame. So when you go to the grocery store to shop, if you have to wear sunglasses and headphones, you just do it and you don't worry about it. And connecting with the autistic community, often online, to share uh, our life experiences with each other. We really need a paradigm shift in geriatric care. Um, Neurodiversity affirming training for geriatricians and care home staff, and more research focused on the quality of life for the 60 plus autistic population. The slogan, "Nothing about us without us," extends to our elders as well. Thank you for listening.
Thank you so much, Jeff. Some really great points. And then I'm just seeing that we've had multiple comments on the Facebook Live, about people receiving their diagnosis in their 50s, whether themselves or a loved one. So it sounds like this topic is definitely resonating, which is why we wanted to focus on it. And we'll have some time for questions at the end, but we're going to go ahead and move forward with our second presenter. So Kathy can go ahead and I'll share the slides for you.
Excellent presentation, Jeff. Thank you so much. So I'm going to expand upon Jeff's excellent introduction to why we're talking about aging and autism and some of the historical challenges that are there, and trying to help understand how that makes a difference in aging, and also the healthcare disparities, especially in terms of getting accurate diagnoses, not just of autism, but of the other underlying causes that may be causing changes in the person. And so hopefully just introducing this in 20 minutes, I'm trying to think how to get across those most important points. But also want to remind all of you, if you haven't seen, we being the National Task Group on ID and Dementia, my colleagues at the University of Texas at Houston, who have us as vendors for a telehealth grant in which we talk about aging, ID, and dementia. And it will be in Galveston Monday, Tuesday, and Wednesday this coming week. And I know that you're going to put a link in. There's still time to register. There still will be a streaming option for those that can't be there in person. This is the last time, though, we will, for this grant, the TCDD grant, be in Texas Live. So I really encourage you, if you'd like to know more about this topic, to come for the 2 days. Excuse me. So let's talk about aging. Understand that each person ages uniquely within patterns of aging. Each one of us will become more of who we are, and also will be impacted even more by the isms that and the stereotypes that we have about people with ID. Or ourselves, as Jeff talked about the autism and not being diagnosed. One of the things that I realize, if I don't have autism, I'm probably right at the edge of the spectrum. And so the stresses as I get older cause more and more frustration and more anxiety and less energy to address issues. So each person ages uniquely within patterns of aging. Aging is aging is aging. We can make predictions about every individual based on the primary factors of aging, the genetics, knowing family history, including medical history, DNA, pre-existing IDD. For people with autism, the complexity of diagnoses, either that have been diagnosed earlier, co-occurring conditions that may or may not have been diagnosed or may have been misdiagnosed. I am more and more, as I do work in trying to help change physical and sensory environments to be more supportive for people with autism, finding people I will meet who will have 9 or 10 other mostly mental health issues or diagnoses that make it extremely complex. And I often wonder if the characteristics we often see in people with autism, if those aren't being misunderstood as a mental illness, or it's dependent on each healthcare provider's educational background and their understanding of autism and other. And so it's just like if you only give a carpenter a hammer and nails, that's what a carpenter will do. If you only give a healthcare provider a misunderstanding about autism and what it is, and a misunderstanding about the need to have 5, 6, and 10 other diagnoses that have the same characteristics, the same kinds of effects on the person's functioning, just really then complicates the whole issue of aging as well. Lifestyle certainly making a huge difference. The physical and social and sensory environments, and the attitude. Spiritual attitudes about aging, attitudes about other people, attitudes about who we are. And whether I always say I am 76, I turned 76 last month. My husband is 79, and we've been trying to recreate the next stage of our old age. Neither of us are good at retiring. And so having an attitude of that we want to continue to stay connected and fully involved in the business we have run and in the work that we're very passionate about. However, that is also impacted by the people around you. The brain for healthy aging needs hydration. I find often one of the major causes for changes and decline in people are related to dehydration, which can result in death if not addressed, and can also result in a person receiving a diagnosis of a type of dementia. Nutrition, rest, movement, rhythm in our life, stimulation without overstimulation, and some predictability is special for people with autism. Next, please. There's a high incidence of the co-occurring disorders. I just want to comment on that. That is a complexity that most healthcare providers do not understand. The other thing that most healthcare providers do not understand, that aging is aging is aging. We need to know the baseline of the person, who each person has been throughout a lifetime, and not compare to others in the population, because every single one of us is a unique human being. And where we need to look for in diagnosing dementia and other underlying possible conditions causing changes, decline, causing trauma to a person, it is compared to the baseline of who the person has been throughout a lifetime. Next slide, please. It's important we know each person's life story. If there are family members or people with autism themselves who are listening to this recording or listening live, one of the best things you can do is collect your life story. Collect the essence of who you are, who you have been. That is part of your baseline, the essence of yourself. And the best way we can continue to function and have healthy aging is by continuing to address underlying conditions that may be causing changes and decline, and finding ways that using our life story, we can interact with our healthcare providers to help them understand our baseline, to not ignore the symptoms they're reporting, but to use those symptoms to work in partnership together to find out what's causing. And in older people, it is always multiple conditions, diseases, underlying issues that are causing the changes and decline. Next slide. The more pre-existing conditions for the age-associated or related conditions, then the higher risk for a diagnosis of Alzheimer's disease. Notice I'm saying a diagnosis of Alzheimer's disease. There are very few people, very few healthcare providers, very few clinicians who know anything about dementia in adults with autism, because of the issues in the historical perspective that Jeff has just provided, and how many adults are out there today who have never been diagnosed. They've always just been known they're different than other people, not known what the difference was. And in a society that doesn't always respect the difference and see it as a strength, it can be even more of a challenge as people grow older to help healthcare providers understand who you have been, who you want to continue to be, and what underlying conditions do you need to explore to find out how they can be treated, what interventions are available. I want you in particular to look at Down syndrome. If you can go back to that slide, thank you. And I mention that because more and more we are seeing people who have been diagnosed with Down syndrome over a lifetime who are now receiving a co-occurring diagnosis of autism, because I believe that there are many sensory challenges for people with Down syndrome that then require any person, a child or person. I began as a preschool special ed teacher before I went back to school, received my master's and then my PhD as a gerontologist. I have never met a child or adult with Down syndrome that doesn't need strict routine, need consistency in life. need to really be able to predict what's going to happen. And I find for many of the people with autism that I have known over a lifetime need that same consistency. We know that the brain also needs exercise for healthy aging as well. Exercise in terms of combining physical and mental exercise together. And so sometimes for people who need such consistency that they can't handle changes in their routine, aren't able to adapt to changes, that can mean that the brain is not getting the same challenges they should be. I find that extremely interesting that more and more people with Down syndrome are being diagnosed with autism. I wonder, just wonder if it's lack of understanding and we need to learn a lot more. Is that really an appropriate co-occurring diagnosis, or is this something that's specific to people with Down syndrome, maybe because they have the same sensory challenges and needs and ways to set up a sensory environment? Understand it is misunderstood because of early research for people with Down syndrome that indicated the pathology of Alzheimer's disease was present in 100% of people with Down syndrome. The automatic assumption, and I've seen this over and over in my career, where the person shows some decline, some changes who has Down syndrome, is automatically assumed to have Alzheimer's disease, and the diagnosis is automatically made. I am becoming concerned that that will also be an assumption made for people with autism, as well as for people with Down syndrome. There never should be that assumption. Current indication is from longitudinal studies that people with Down syndrome are at about a 56% risk of Alzheimer's disease during their lifetime, which means there are 44% who do not show the significant losses and changes. That's extremely important. We also need to be doing the longitudinal studies for people with autism to see changes in baseline and to find out what are the underlying causes, and never assume automatically there should be an automatic diagnosis of Alzheimer's disease. For people with Down syndrome, by the way, we assume that they age into, and this is with good information, age into their risk factors about 20 years earlier than the general population. So 56% of people in the general population by the age of 80 are at risk for being diagnosed with Alzheimer's disease. Exact percentage, or almost exact percentage, as people with Down syndrome by the age of 60. That is really significant. I am hoping we will be doing research and studies understanding aging, adulthood and aging in people with autism, and look for similar kinds of incidents about the pathology. There are many that believe that there is no risk for people with autism. And then there's others on the opposite end that assume that it's extremely high risk, closer to the 100%. Next slide, please. Just life expectancy for people with autism is significantly lower at this point, about 72 years old compared to the average actually 72 is about the average. These are pre-COVID figures. This may change as we start to get in information about how COVID has affected life expectancy in different populations of people. For people with autism, depending on the severity of the autism, how the person is impacted and how quality of function in life and connection to the world around is impacted, we're looking at 39.5 years to 58 years in life expectancy. And these are for people who are profoundly impacted by autism, and I suspect not very accurate figures, since the research has not been really aggressively pursued. Next slide, please. Mentioned that the most important thing to understand from what I mentioned a few minutes ago, there is absolutely no population of people with any pre-existing diagnoses, conditions that have 100% risk for Alzheimer's disease or another type of dementia. That's including people with Down syndrome, that's including people with autism. And understand the sensory challenges for people with autism are on a range. The sensory challenges are the same challenges all of us face in different ways. We all have the capacity to be able to use our sensory information, and I'm going to talk about that in a few minutes. But we also have similar challenges. Each one of us, again, ages uniquely within patterns of aging, and we need to understand that in terms of people who have pre-existing conditions. So let's talk about what is dementia. Next slide, please. It's on that slide. These are the four most important facts to understand about dementia. The term dementia is a term for a loss of cognitive or thought function severe enough to interfere with daily function, and also a loss compared to who the person has been throughout a lifetime. If I've spent a lifetime, I'm lost in hotel hallways. I can find my place through a map any place in the world, but I get in a hotel hallway, especially when I'm leaving my hotel room, I never remember which way I have to go to find the elevator to go to the exit. This many years now, I'm using cues. I pay attention to which hand I turn towards to my hotel room. I look for the cues in the hotel hallway, and more and less often am I doing this. But if I were suddenly right this minute placed in a moment of stress in a hotel and I had to walk outside that hotel room, I would probably be lost. That is not cognitive change or decline, and that does not impact my daily function compared to who the person has been. Since many healthcare providers are not familiar with people with autism and adults with autism, they may not understand that the baseline of functioning for each one of us is uniquely different. For each adult, regardless of pre-existing differences, and they may have already spent a lifetime with adaptation to being able to adapt to the sensory information and how we use the sensory information. Though Jeff made a very significant point that as we get older, we are increasingly likely to have increased impairments, especially vision and hearing. We are also likely to have challenges of vestibular, being lost in space and time, not being able to locate themselves. Without the vestibular capacity, we can't take in the other sensory information. We also cannot connect to the world around us. None of this is taken into account by a healthcare provider who may not be trained in this, and so they may always be comparing a person to someone else in their patient population and assume that the loss of cognitive and functioning is a type of dementia instead of understanding this is the person's baseline. The term dementia describes a group of symptoms. It is not a specific disease. That is one of the most important concepts to understand, because oftentimes in my years as a gerontologist with a specialty with IDD and aging in persons with IDD, oftentimes I will see that the term dementia is the diagnosis, which is telling caregivers, the person themselves, telling other healthcare providers nothing, because in older persons, there are always multiple losses and changes that occur. increase in visual impairment from baseline, hearing impairment, increase in difficulty of locating ourselves in space because the vestibular sensory system has been damaged, or difficulties in processing the sensory information that's come in, or maybe we have a visual impairment, and many people with autism are dependent on vision as their primary way of taking sensory information in after they've been located in space. Now they have increased visual impairment. Now they have even more difficulty with the vestibular being able to locate in space. So for a doctor to say that someone has dementia, especially someone with autism that we haven't done the research on, all we're saying is we notice that there is a change in function, a decline in maybe cognitive capacity that affects daily living, but just may be caused by something other than dementia. There can be hundreds and hundreds of things, conditions, diseases that can cause what looks like what we call Alzheimer's disease, the most commonly diagnosed dementia. The condition we refer to as dementia may be caused by many things. Some of them may be treatable. I mentioned the need for hydration for the brain a few minutes ago. Dehydration, B12 deficiency are treatable conditions that can cause a person to look as though they have some other type of dementia like Alzheimer's disease. Some are irreversible. Myself and some of my colleagues in the National TAP group, PASS group, and other groups I work with do not use the word irreversible because it implies there is nothing we can do when there is much we can do. Understand that there is no population of people that dementia is normal aging. Dementia is a disease process often caused by underlying conditions that can be beyond the plaquing and neural fibril entanglement of what we think of Alzheimer's disease. And I see my time is getting shorter and shorter. Next slide, please. I want you to see there's a few more slides I'll probably have you move down through. These are the most commonly diagnosed irreversible dementias. Alzheimer's disease in the middle, you can see, is the most commonly diagnosed. Notice I keep saying diagnosed, and I'm not saying commonly occurring, because I think there are many people in the general population. There are many people with different types of ID, including people who have ID and autism, and people who do not have ID but do have autism, who are being misdiagnosed, who are being diagnosed, and the most commonly diagnosed Alzheimer's disease is also the one that most people, most healthcare providers know something about, may not have been trained about vascular dementia, which, by the way, at least has some tests that we can more conclusively conclude that there is a vascular dementia causing changes and decline from who the person has been from baseline. But we also can have co-occurring vascular dementia and Alzheimer's disease, or Parkinsonian dementia, which is usually a person who has Parkinson's disease, that can advance also into damage that causes problems of sensory processing disorders, making it difficult to use the sensory information that is still able to be received. For example, locating ourselves in space, vestibular system is through the joints and the muscles of the body. COVID is a great example, was a time when many of us lost muscle mass because of being more sedentary, some people being hospitalized or bedridden because of having COVID or other co-occurring conditions. We know that there's been a huge loss of muscle mass. That means for many of us, we have less receptors, external receptors that can take the sensory information in, helping locate us in space, meaning that not being able to locate in space, the vestibular system being able to be stimulated and to be able to process, interpreted that information, means that we also can't take in the other sensory information accurately or process that information. Any one of these, frontal temporal dementia, dementia with Lewy body, are a different type of damaging to the brain. Looks different than the damage that occurs for people with Alzheimer's disease in the brain. All of these impact the sensory reception, the receiving of that sensory information, which also may be reduced or mistakenly sent, the information sent incorrectly to the brain, and sensory processing to make it look like a person is confused, disoriented, and lost in space, especially if someone has a pre-existing diagnosis of autism, may extremely likely be confused and be looked at as Alzheimer's disease or another type of dementia, rather than understanding this is baseline functioning or this is a sensory processing issue, that we can have other types of ways that we can help the person adapt. Next slide, please. I'm going to hurry down through the slides because, of course, I over-prepared slides. Understand that especially for Alzheimer's disease, it is a diagnosis of exclusion. No one can go to a healthcare provider's office, or should, and in 1 or 2 visits receive Alzheimer's disease as a diagnosis of exclusion. It is impossible to determine it is exclusion. Excluding and treating when possible as many of the underlying conditions causing the decline and changes for the person. You can see the multiple types, and a person can have 40 to 50 possible pre-existing conditions that can look like Alzheimer's disease or another type of dementia. Next slide. Not sure. I think I'm going to be close to, unless I don't know if I think there was at least one question. I think this will be close to the last slide that I'm going to do, except to go down to the bottom. This is the most important thing you can take from my talk today. Diagnosing dementia should always be conducted through a differential diagnostic process, the process of ruling out possible underlying causes for decline and treatment when possible. The sensory reception challenges, the possible difficulty of sending that information to the brain to receive that information, and then the damage that's caused to the brain can then mean that information that is received is no longer able to be interpreted, and the brain to be able to determine the reaction to that information that is coming in. Like the term developmental disabilities, dementia is an umbrella term for the observed symptoms of loss and changes. It is essential that a differential diagnosis is conducted for each and every person, especially for people with autism who may not, healthcare providers may not have a lot of experience or understanding. Know that for each of you who are listening to this, start collecting and documenting life story, including how you take sensory information, interpret it, how you connect to the world around, because the most important thing that has to happen is to stay connected to the universe, stay connected to others, to the previous functioning and activity over a lifetime. It is essential that we all together start research and questioning, making sure we can determine what are likely underlying causes for a person with autism that we can help rule out or rule in and treat. The other issue I think it's also important to understand, for people who do have autism, it is important that we're all working together to learn from you, because you have learned with sensory challenges how to adapt to the physical and sensory environments. I have learned so much that I use then. This is how we can support people with dementia that have actually a dementia to stay connected to the world around. And so I think we're communities that need to be together. If you can go to let me go to the slide that has the EDSD on it, please. I think you passed it. It's all the way up. It's up closer to diagnosing. It's a brown. It'll show. I can see it's the brown and red. Keep going. Okay, this is a tool that has been produced. Dr. Lucy Esrelu in a subcommittee of the NTG. This is the NTG EDSD. It is a tool not for diagnosing types of dementia, or indicating baseline and change from baseline, who the person has been. That is the most important information you, advocates, caregivers, healthcare providers need to know. What has changed, what symptoms show the changes, and that helps us determine what are the underlying causes for changes and decline in a person. We need to make sure the myths and stereotypes about people who are diagnosed with an autism earlier or later in life, or people who are not diagnosed at all, but appear to be different than other people. And that could be myself. I'm very likely that's myself. To make sure that we're determining what is a change and a loss from who the person has been from a lifetime, and how does it affect daily living. If it doesn't affect daily living, it doesn't matter at all. If it affects quality of life, function in daily living, and the ability to stay connected to the world, that's what matters. And this is available free on the NTG website. I don't know. It's also the same link, on the same link, I think, that Adriana may have given you to be able to register for the workshop that's coming up. And we also will be discussing the EDSD in the workshop. To the very last slide, please. Thank you for attending and listening. Thank you so much for inviting me to be here. I think I probably learned more from you than you have learned from me, but I hope together we can continue to communicate. There's so many questions I have for you, Jeff, and others that I'd like to talk about, especially in terms of sensory reception and in terms of sensory changes and adaptive ways to be able to continue to stay connected to the world. Thank you so much.
Thank you so much, Kathy. We really appreciate your expertise. I know it can be challenging when you just, have so much information on a topic to condense it, but we really appreciate your insights. I think we did have a couple of questions just with our last few minutes. Mm-hmm. The first was where an adult can go to get a diagnosis. For adults, you generally need to see a psychologist, and you want what's called a neuropsychological assessment. We do have a resource guide on our website, so you can put in psychologists, and it'll bring up a list. You can filter by your service area, and then also you can always reach out to us. We have a contact form with Autism Society of Texas for folks that need support locating resources near you. So if somebody's wanting to navigate the process of adult diagnosis, you can always reach out to us as well. But I don't know if either of you have thoughts about that question.
Yeah, I would just say that what you mentioned is really important. Depending upon the reason a person is seeking a diagnosis, if you're wanting some accommodations at work and school, Dana's point is a very important one. You must find a licensed psychologist, that's a PhD, PSYD, a psychiatrist, or a specialized neurologist. So most therapists and counselors cannot provide the formal medical diagnosis that's required for those disability accommodations at school or work. And for people, there's many differences between systems here in the US and, let's say, in the UK. Here, you're responsible for finding your own provider and navigating your insurance policy yourself. Other parts of the world are different. Like in the UK, they have their public health system. as well as a private market too. And wait times are different. Like for insurance-based wait times in the US are more than the private market, which is more expensive because you're paying out of pocket. And it really depends upon the area that you're in. Um, the typical tests that you want to make sure um, that are offered. Uh, Generally in the US, you have several. The ADOS-2 is kind of considered one of the ones for adults specifically that's used. That was what was used for mine. And the MIG-DOS-2 is a newer one that's becoming popular. The ADOS-2 is also used in Europe and other places as well. Um, and as I think Kathy mentioned, you want to make sure you have as much information as you can gather before going in. If you haven't taken an online questionnaire, a screener, sorry, like the Autism Quotient screener is one that can be helpful. And then the problem with being older is your parents may no longer be living to be able to describe what you were like as you're young. So to the best if you can, if you have siblings, that can be helped to interview them about maybe some autistic traits. And then as far as where to go, I'm sure Dana mentioned the resource online. I just used Psychology Today and went through, and filtered with autism and adult. And then I actually went to my general practitioner first with all that information that Kathy said. So I had just, a ton of information, and then got a referral based upon who I already found that I thought might be able to do a good job in my area.
Thank you. Yes. And then just if anybody just has a brief thought or wants to distill a soundbite, what advice would you give a younger autistic adult thinking about the future?
Sky's the limit. You're autistic. That's a different way of being. Don't let anyone define what you can or can't do in your life. There's plenty of autistic people that um, are in a lot of unusual vocations or places contributing to society, and are doing just fine. And don't be afraid to advocate for yourself, um, especially in educational and work environments.
Can I also add to that, please?
Yes. Yeah.
Please share with others how the sensory environment feels to you and how you adapt to it. I'm a firm believer. I have been trying to understand and research autism for 30 years now, because many years ago, I really began to see the environment of what difference we can make for people who have Alzheimer's disease, or for older people in general as they have increased impairments. There is so much we can learn for how others have adapted to the environment and the sensory issues. I always say, take the problems out of the person, put them in the physical and sensory environment and make the changes. But the more you can share your experiences of how it feels and how you've adapted, the more we can learn to make that physical and sensory environment something that keeps all of us connected to the world.
Yeah, thank you for that, Kathy. I do think that's important, especially because I think for people who are diagnosed later in life or, sort of discover, self-identify or whatever their process is later in life, I think kind of undoing the threads of sort of all the things, you've done for yourself to accommodate your sensory needs without maybe conscious awareness, that can be a big thing to untangle. But then also just communicating it, like making sure other people know, so that if you need help or you kind of need someone, to support that better, as you're aging. Yeah, I think that's something I hadn't really considered. Yeah, and just, a comment just saying, not enough research has been done, and I agree, especially when we're getting kind of all of these co-occurring things and, how, each one impacts the other. I think oftentimes so many things are researched, in isolation, but that's not people's lives, are much messier. So yeah, I do think we have a lot to learn, and we know that any of these topics, could be 8, 12 hour webinars. So, we're just barely scratching the surface. We can always revisit topics in the future, but thank you both so much for everything you've shared, and hopefully this can at least get people's wheels turning, kind of get people pointed in the right direction of where to go next. So thank you so much.
Thank you.
Thank you.